Hi everyone, thanks for tuning in. I'm Alex and I'm going to be presenting some of the key findings from the ACDS survey on respiratory motion management. The ACDS is currently developing a national end-to-end audit to incorporate motion and respiratory motion management techniques. Before diving into the implementation of this new audit, we wanted to perform this survey in order to capture the current state of motion management in Australia and New Zealand. Specifically, what we were hoping to find were the patterns of utilisation of the various motion management techniques, as well as practically how each of these techniques are implemented in the clinic, with the goal here being to arrive at an audit that was really informed by facilities' current patterns of use and to hopefully future-proof against future patterns of use as well. The survey was conducted using REDCap, which is a secure online platform hosted at Peter Mac. It was distributed to all ACDS subscribed facilities at the end of last year, who were allowed 3 months to respond. In the survey, we defined motion management as any treatment technique aiming to mitigate the effects of intrafraction respiratory motion. We considered the following 5 categories of motion management across 3 main anatomical treatment sites and 2 combinations of fractionation regime. Conspicuously, breast was not one of the sites that we considered, and this is simply because we know that breast is not going to be within the scope of the audit, and we did not want to capture this data. Overall, we had a really great response to the survey, with 78% of facilities in the region completing it in full. We also had really good representation amongst the key demographics in the ACDS database, metropolitan regional facilities and public and private facilities, so we're actually quite confident that this represents an accurate snapshot of where we're at with motion management as it stands today. Of our 87 respondents, 85 of them said they used motion management. This is just a number to keep in mind to help contextualise some of the results I'm going to be presenting throughout the talk. So how do we use motion management in Australia and New Zealand? Well, everyone who uses motion management uses the ITV approach. This was unanimous amongst the people who said they use motion management. 41% of these facilities also use breath hold gating, and remember, this is outside of the context of breast radiotherapy. Free breathing gating and tumour tracking are used pretty sparingly, and the mid-ventilation approach is not actually used at all. If we look at how each of these techniques are used in combination with different treatment sites across different types of treatment, we can see that ITV treatments to thoracic treatment sites, such as the lung, stand head and shoulders above any other combination that we examined, with the next most commonly selected being upper abdominal treatment sites, like the liver and pancreas. If we just zoom in on the SABRE data, comparing these 2 anatomical sites for the ITV approach, we can see that almost 90% of facilities said they do SABRE to the thorax, but only about 40% of facilities said they do SABRE to the upper abdomen. So there's clearly some issue other than access to the technology that inhibits certain facilities from treating this site. If we compare the same 2 groups in the breath hold gating data, we can see that they're treated in much more similar proportions, but neither of these proportions are really that close to the total proportion of facilities that say they do breath hold gating, and in fact only 14% of facilities told us that they treat both the thorax and the upper abdomen in combination with breath hold. So once again, while access to the technology or the technique of breath hold gating seems fairly widespread, there are clearly some other factors at play which determine facilities' actual decision to treat certain anatomical treatment sites. If we look at how the different motion management techniques are utilised by our different demographics within the ACDS database, public and private facilities and metropolitan and regional facilities, we can see a skew towards metropolitan public facilities in terms of the utilisation of breath hold gating. However, we didn't see any statistical significant differences in proportions between these groups for either of the 2 more prominently selected motion management techniques. If we examine the treatment sites, the sites that are treated in combination with motion management, however, we can see that overall metropolitan facilities treat every location in greater proportions, in particular the upper abdomen, liver and pancreatic treatment sites. And we also saw a statistically significant difference between public and private facilities in the treatment of this site as well. And I actually think this is one of the more interesting outcomes of our data. So how are people implementing motion management practically? Well, one of the first questions we asked was whether or not they use motion limitation, and overall motion limitation is fairly sparingly used, in particular for the lung. But we can see for upper abdominal treatment sites, almost 50% of facilities told us they actually use some form of motion limitation, and about 20% of them told us that they wouldn't treat this site without any form of motion limitation. So this is sort of positioned as potentially a factor in facilities' ability or decision to treat this site. When people are using motion limitation, it's nearly always abdominal compression devices like the belt you can see here. And if it's not this device, it's some other form of external fixation. Ventilation-based approaches were not really used at all in our survey. And importantly, the patterns of response to this question were not different in any of the demographics that we examined. We also asked the facilities to tell us what types of imaging they might use to assess motion prior to treatment, and we're just looking at the cumulative responses for every combination of treatment site and motion management technique for SABRE and conventional treatments here. Certain imaging modalities like PET-CT, 4D-CT and 3D-CT, they're used in really similar proportions regardless of the type of treatment. But other imaging modalities like 4D cone beam, fluoroscopy, MRI, contrast CT and breath hold CT, these are really skewed towards the SABRE side of this plot. When we drill down into this data, however, we can see that the increased rate of selection for imaging modalities like fluoroscopy, MRI and contrast CT can really be attributed just to the one anatomical treatment site. And once again, it's the upper abdomen, liver and pancreatic treatment sites. So this raises another potential factor in facilities' decision to treat or ability to treat this site, and it's potentially access to certain imaging modalities because they appear to be a higher priority for the facilities that do treat this site over treatments to the thorax and lung. And once again, responses in this section were not different in any of the demographics that we examined. Finally, we asked the facilities to tell us what types of data sets they're using to calculate dose. And in this question, the patterns of response were really dictated by the choice of motion management technique, with breath hold gating. The most common selection was breath hold CT, as you may have guessed. And for the ITV approach, the most common selection was the average intensity projection from all bins of a 4D CT. We did see some influence once we looked at the abdominal treatment sites who used motion limitation, and that's where we see these smaller bars coming in here. But overall, the most dominant choices for the different motion management techniques were still the two really big bars that you can see on this plot. And similarly, the patterns of response in this question were not different in any demographic that we examined. So what does this all mean for our impending audit? Well, the data tells us that we really do need an ITV case, and this should really be a lung SABRE case, because this was a case that was ubiquitous amongst nearly every facility who answered the survey. And so it would be a really nice addition to the national database, allowing comparison between almost every facility in the region. We should also be seriously considering a breath hold gating based case, because almost more than 40% of facilities in the region use this technique, and liver SABRE is really well positioned to be a good anatomical site for this, not only because it's the most common site that's used in combination with breath hold gating, but because there are significant procedural differences in the treatment of liver with respect to the lung. There's more use of multimodality imaging, and I didn't show this data, but more varied and potentially more complex image guidance procedures. So if our audit was framed around these two cases primarily, we would be able to assess two distinctly different workflows for the two different anatomical treatment sites, as well as two distinctly different motion management techniques that are popularly used amongst facilities in the region. We will be able to audit these cases on the ACDS customized CERS Phantom. The main drawback here would be that we can't really audit the use of motion limitation strategies, despite the fact that they are actually quite commonly used for treatments to the upper abdomen. And this is really because in breath hold gating, the motion management technique in and of itself is the motion limitation strategy, so it doesn't make sense to test the use of abdominal compression here. And we just didn't see the lung SABRE as a particularly fruitful use case for abdominal compression either. Further to this, the audit probably is not going to be capable of assessing the patient triaging process, where you actually determine the patient's suitability for different motion management techniques. It wasn't quite captured in the scope of the survey, but this would be extremely difficult to replicate on a Phantom. Future directions for the audit would likely see it including free breathing gaining and tumour tracking as well. But importantly, another important result out of the data was that there were no significant differences amongst any of the demographics that we examined. So whatever audit procedures we come up with, they're going to be widely applicable, which is a really excellent result. So huge thanks to everyone who participated in the survey and completed it. It was a pretty arduous task and there was quite a few sections, so we're really grateful for the community for doing their bit to contribute to this data. It's been extremely useful so far and I'm sure it will continue to be into the future.